Yes, good morning. This is Iremba Wilfred, who is going to take you through some slides of surgery, and this is surgery 1. Our major objective today is to get introduced to surgery. We should be able to define the term surgery. We should be able to review a brief background of surgery, where it came from. We should be able to outline at least the aims and the principles of surgery and be able to differentiate the different types of surgeries. We should also be able to appreciate and list the common surgical condition, and then we can be able to describe the pre, the intra, and the post-operative surgical management. So as earlier on we had said, we are able to define surgery. Surgery is a branch of medicine which deals with the management of conditions by surgical interventions or operations. This can be done by instruments or sometimes by manual separation, that is use of the hands. The historical background of surgery. Surgery is an ancient method where operations were performed crudely, like cutting off the affected part with man or with men holding the patients. They would hold the patient manually and then they cut the affected part without use of any anesthesia or reduction of pain in any way. But currently there was no anesthesia, as I have said. Septic technique was not much observed. Patients were at high risk of infections, and some of them would die due to pain, infections, and septicemia. When we say septicemia, this is accumulation of microorganisms in the body. There were no trained health workers, but strong men used to be the surgeons on the front line. Modern surgery and training of surgeons solve the above problems by use of anesthesia and aseptic technique. This is what we are using currently in a modern way. And that's how surgery was before. They used not to use any anesthesia. They would hold man manually, and then they had to cut the part that is affected. But currently now, we anesthetize someone, we reduce the pain, and then someone goes into surgery. They remove the part that is affected, they correct the part that is affected, they correct the part that is diseased, and this is the joy that we have today in the modern surgery. The modern surgery is not like the other previous surgery that we used to have. And the aims of surgery that we look at and basis on, they are basically four. One is for diagnostic purposes, that is to say they can remove a biopsy or a small meat and then they take it to the laboratory to rule out the cause of the disease that may be affecting someone. And aim number 2 is for curative purposes. This is when they remove the injured or the damaged organ for curative purposes. Aim number 3 is for preventing purposes, that is amputations and other things. And then aim number 4 is for palliative purposes, and but this involves the use of radiations. So basically those are the 4 aims of surgery. I repeat them. 1, we are saying it is for diagnostic purpose. Number 2 is for curative purpose. Number 3 is for preventing purpose. And then lastly, number 4 is for palliative purposes. In most cases, when people have incurable diseases and probably the part is affected and cannot be restored, what they do, they take the person under palliative, whereby they are just going to do the ongoing management of the patient, and probably improving someone's well-being. So we have different types of surgeries, and basically we are going to look at 3. However, there are many. One of the type of surgery that we are going to look at is emergency surgery, and we shall have to understand what do you mean by emergency surgery. Number 2, we have what we call planned or elective surgeries. Still, we need to get to know what they are into details. And then sometimes we have what we call multi-staged surgery. Still, it's the same issue that we need to understand what they are. Briefly, if I may give a preamble of these categories of surgeries. Emergency surgery. This is a surgery that is done in emergency states. In other words, in conditions which require immediate attention. They were the ones we call emergency surgery, without any delay. For example, if someone has an obstructed intestine, or which you call IO, the same obstruction, that is an emergency that may require immediate attention. Number 2, if someone has a burst abdomen or ruptured abdomen, maybe they did surgery and there was a separation after the surgery, then we do an emergency operation, which we call emergency surgery. For the case of planned or elective surgery, these are the types of surgeries that are done when you have fully prepared the patient for surgical intervention. You admit the patient 2 to 3 days before. You work upon his or her well-being, make sure that he's in good condition, and then the person can be taken to theater for any operation. That is to say, you will have prepared the patient physically, psychologically, socially, even spiritually, meaning that you're dealing with the patient in totality. The patient will go to theater when he's fully prepared, and this reduces the risks of complications that would have resulted or that may result during or after the surgery. The multi-staged one, this is where the surgery goes into stages. They start with a simple surgery, they upgrade it until the whole disease is treated completely, and then the person recovers. That is multi-staged type of surgery, and usually this is done in big conditions, whereby they will wait for the wound to take some healing process, and then they go on suturing the wound or debriding the wound until someone heals completely. That is multi-staged type of surgery. And the principles of surgery, they are basically 5. 1 is for safe administration of anesthesia, and when we say anesthesia, this is the drug given to reduce on the pain of someone. Number 2 is to prevent or treat circulatory failure. In other words, when we are dealing with surgery, we need to prevent any occurrence of circulatory failure. Number 3 is for quick wound healing. And quick wound healing, we mean once they take on the operation, the wound should heal as fast as possible, and that is a principle or a core principle of surgery. Number 4 is to prevent or treat any complication that may result during or after the surgery. And then lastly is to restore the function of the affected part. Those are the 5 core principles of surgery. I may repeat them by saying 1 is for safe administration of anesthesia. Number 2 is for preventive and treatment of any circulatory failure. Number 3 is for quick wound healing. Number 4 is prevent or treat any complication that may result during or after the surgery. And then lastly, number 5 is to restore the function of the affected part. So surgery basically is classified into two categories. It may be a major surgery or a minor surgery, or it could be an emergency or planned surgery. That's how we classify surgery, and I'm saying it is classified into two. One, it may either be a major type or a minor type, and then it can either be an emergency depending on the state, or a planned type of surgery where instead you organize, you prepare the patient fully for the surgery, and then at the end of it all, the patient should be able to heal without any complication. So what do you mean by major surgery? Major surgeries, these are surgeries that requires general anesthesia. In other words, you make a person to sleep completely, and so that cannot be able to feel any single pain that is involving the surgery. And then minor surgery, this is done under local anesthesias, whereby you inject, you numb that specific part that you're going to carry on the surgery. That is a minor surgery. This is always done locally. It can be also be done in OPD without involving the use of theater. And the emergency, I've already explained it. The planned, I already explained it. So I would love us to switch our mind to the common surgical conditions that we are likely to look at in this surgery course unit. One, and which is basic. One is inflammation, following injuries or following trauma or following diseases. Number 2, we shall cover surgical shock. Surgical shock develops inadequate or reduced supply of blood to the vital centers. And when we talk about the vital centers, we are basically meaning the heart, we are basically meaning the brain, the liver, those major organs that we call the vital organs. Number 3, burns. Burns could be scalds, which might have been caused by hot substances or wet substances or dry substances. And number 4, we shall cover hemorrhage. 5, tumors, fractures, and other surgical conditions that may affect the whole body system. And when you talk of systems, I understand you know them from the anatomy and physiology. Some of the systems, we have the skeletal-muscular systems, we have the cardiovascular systems, we have the urinary systems, we have the endocrine systems, we have the digestive system, the reproductive system, to mention but a few. And those are some of the conditions that we may look at as far as the surgical lessons are concerned. For any question, please you can keep it, note it down, so that at the end of this lecture you can be able to forward it to me, or you can call me on the number that I'm going to give, which is 0774 122 842. I repeat, 0774 122 842. That number is on WhatsApp and belongs to me. So we talked about the pre-operative management, the intraoperative management, and the post-operative management. What do you mean by this? Pre-operative management, this is the care or the management given to the patient in preparation for the operation. In other words, before the patient is going for an operation, that care you give specifically to prepare the patient for an operation is what we call pre-operative operative care or pre-operative management. And this can also be given in outpatient, or the patient may be admitted on the ward some days before an operation. And then you take care of this patient psychologically, physically, socially, spiritually, to mention but a few. What is involved in this care? One is admission. Admit the patient in a surgical ward in a well-ventilated room. The room must be further described according to the condition. Where you're going to admit the patient or where you're admitting the patient should be convenient for the patient and should be favorable, well-ventilated in a well-made bed. What do you mean by well-made bed? A bed without creases, a bed with clean bed sheets, a bed which is real good for the patient. Then number 2, we create rapport. This is the establishment of a nurse-patient relationship, and it is created by greeting the patient, self-introduction, offering a seat or offering a bed to the patient. Rapport is very important to attain the confidence and the trust from the patient. It creates confidence and trustworthiness between the patient and the health worker who is going to work upon this patient. Following rapport, we need to take history. History taking is very important, and this is taken as follows. 1, demographic data, which involves all identification data. Number 2, we need to look at subjective data, which data or which information is given by the patient or the relative. And then we talk about the objective data, which the doctor or which the health worker finds out by himself. This can be done by observation or removing investigation from the patient. History taken from the patient include the following, among others. 1, the past medical or surgical history, the psychiatric history, family history, social history, obstetric and gynecological history if is a female, and many other histories. Those are the histories that you can take before you take the patient for any surgical intervention. After taking this history, we need to inform the doctor that we have the patient, and then the doctor will have to come and assess the patient. Meanwhile, we shall be doing our nursing part. That is to say, take observations, and these observations must be taken and recorded on the patient's chart. The observations we are talking about, we have them in 3 categories. 1, we have the general observation of the patient from head to toe and the general condition of the patient. Number 2, we talk about vital observations, that is to say temperature, pulse rate, respiration rate, and blood pressure. And then number 3, we take note of the specific observation according to the kind of condition you are dealing with. These must be documented on the patient's observation chart for consistency and continuation of care. Meanwhile, when the doctor comes, he or she will examine the patient with an assistance of the nurse who has been there, and this nurse should be able to give the history which he has done and the observations which he has taken, give them to the doctor so that the doctor can know where to understand where to start from. During the physical examination of the patient, it will involve 4 parameters. One of them is inspection. The doctor will look at the whole patient from head to toe while observing for any abnormality, and these abnormalities must be documented in whatever way the patient looks like. Number 2, we look at palpation. The doctor or the nurse will use the fingers to feel any mass or swelling on the patient's body. To palpate is using your hands, using your fingers, touch the affected part. This palpation may be superficial, that is to say, just on top or deep. That means you're going to apply more pressure and feel any abnormality that might be in cavity. And in most cases, when you look at palpation, it is done on cavities that have organs inside them. And majorly when you look at these organs, we are looking at whether organs are enlarged or the organs are swollen. That's when we do a deep palpation. Friends, be cautious with doing a superficial palpation, especially if you're doing it on an opposite sex. You know what I'm meaning, okay? Number 3, we'll talk about percussion. This is by use of the finger pads of the middle finger to listen to the sounds of the internal organ. To percuss is you put your fingers or your hand on the part that you are percussing, and this percussion, it is aiming at listening to the sounds that may be produced. Now, what do we mean by this? Usually when we are comparing these sounds, you look at empty jerrycan and a jerrycan full of water. An empty jerrycan, when you knock on it, it will always produce a sharp sound, meaning that is empty. But a jerrycan full of water, when you knock on it, it always produces a dull sound, meaning that is full of a fluid inside there. Meanwhile, as we are doing the palpation on these specific cavities, this is what we are looking for. If you're knocking or if you're percussing on the cavity and it is producing a sharp sound, meaning that the cavity is not composed of any fluid, or it is not composed of any air, which will produce that sharp sound. But if it has the fluid inside, the air inside, it will end up producing a dull sound. That is an indicator that there's something wrong taking place in that specific part. And then lastly, we talk about auscultation. This is the use of a stethoscope to feel for any abnormal sound. Stethoscope. I know you guys we have been using stethoscopes and to take blood pressure, to listen to moving things like in cavity, abdominal cavities, or you're listening to how the heart is beating. That is to auscultate. And auscultation, it involves examinations of systemic systems. Examination is done systematically and in that order, with exception of the abdomen, where palpation is done last. Why do you think so? Why should we palpate the abdomen last? That's a question should be on your mind. But in the long run, you shall get to know why we should palpate the abdomen last. After examination, we have inspection, or the doctor has inspected, has percussed, has palpated, and has auscultated. Then there will be a need for ordering the investigations. And these investigations, we have what we call hematological investigations, which involves blood. Anything that is involving blood, it is called hematological investigation. And which investigation do we do on blood? Full hemogram, random blood sugar, we do white blood cell count, we can do blood slide. Those are hematological investigation, ESR, erythrocyte sedimentary rate, and many others. These are done for diagnostic purposes. Category number 2 of the investigation, we have what we call radiological investigations. And these radiological investigations, they involve x-rays, they involve computed tomographic scans, they involve ultrasound scan, they involve magnetic resonance imaging. And then category number 3, we have what we call urinalysis, which involves urine. It may be urine for sugars, urine for culture and sensitivity, urine for urinalysis, etc. And then 4, we have sputum. Sputum investigations, where sputum can be used for AFBs to rule out tuberculosis. And then category number 4, we have stool, for either stool analysis, stool for culture and sensitivity, stool for occult blood. It is all these investigations are done to make what you call a medical diagnosis. Point note: the nurse is supposed to carry out all the investigations as ordered, and the results should be picked from the lab and then put in the files of these patients, because the nurse or the doctor may come in and check in the files and then should be able to see that all investigations taken, all investigations ordered have been received, and then can be able to treat the patient appropriately. What does this mean? Meaning, after investigations and doing all these examinations, then you should be able to make a plan to treat the patient or manage the patient. And this management, it is in 2 categories. We have what we call pharmacological management. Pharmacological, it involves the use of drugs, okay? Pharmacological drugs. And then we have what we call non-pharmacological. Basically, that is nursing, and you know what we do as nurses. Depending on the condition of someone, these 2 will vary: pharmacological and non-pharmacological. Pharmacological may involve use of antibiotics in case there's any suspected bacterial infection, may involve analgesics, may involve hematinics, may involve antiviral, may involve many others. And then for non-pharmacological, as I am saying, these are mostly the nursing care part. One is diet. If you're looking at diet of someone who is going for an operation, of course you need to give a well-balanced diet, which is well composed of nutrients that may require in the quick healing of the wound of someone. And then it involves collection of ordered investigations. It involves exercises, hygiene, care for bowel and bladder, giving different therapies, giving advice on discharge, and then lastly should be able to discharge the patient if the patient has improved. That is all for today. I hope we shall continue from there in another day. Thank you. I appreciate your attention. I appreciate your contribution. I'm waiting for your questions and any additions that you feel may carry value on this piece of work. I wish you the best. I remain Iremba Wilfred, a surgery teacher. Find me on 0774 122842. That number is on WhatsApp. Anytime I welcome your questions. I wish you the best. Stay blessed.